Welcome back to the deep dive. Our mission here is simple. We take these stacks of complex professional sources, research papers, clinical notes, and we really try to extract that mastery level knowledge, the shortcuts, if you like, to elite understanding.
And today, we are immersing ourselves in two conditions that, frankly, have a huge impact on reproductive health: endometriosis and adenomyosis. Our goal isn't just a quick overview. We're aiming for a comprehensive command history, pathology, the clinical picture, and the very specialized ways these are managed.
Right, the kind of depth you need at the highest professional level. We often start with something that really cuts through, and the source material gave us this quote. It perfectly sets the tone. Whereas cancer can kill the woman, endometriosis cripples her life.
That immediately frames it, doesn't it? It highlights the chronic invasive nature, the devastating impact on quality of life, even though it's rarely lethal itself. It underscores the gravity of the pain and the systemic issues we're going to unpack.
Absolutely. So for mastery, we need those clear definitions right at the start. Endometriosis, first described way back, Karl von Rokitansky, 1860.
That's right. And the core definition holds. It's the presence of endometrial tissue, and crucially, that means both the glands and the stroma anywhere outside the uterine cavity's lining.
Simple definition, but the prevalence. Well, it's quite startling when you dig into the numbers. The overall reported incidence is around 10% of women of reproductive age globally.
But that 10% is just the baseline. It really jumps depending on who you're looking at. For practitioners, these numbers are key. The incidence nearly doubles, up to 20%, in women presenting specifically with infertility.
Wow, 1 in 5.
Exactly. And for women battling chronic pelvic pain, it's about 15%. And interestingly, the sources specifically call out a remarkably high incidence rate among Japanese women. That suggests there might be specific genetic or maybe environmental factors playing a role in certain populations.
So a condition potentially affecting 1 in 5 infertile women. Understanding its behavior is absolutely essential. Okay, let's get into the weeds.
So let's unpack the basic nature of this tissue. Our sources emphasize that endometriosis is, fundamentally, a benign proliferative growth. But, and this is key, it acts a lot like cancer in some ways.
So?
It actively invades the tissues around it. It shows a real tendency to grow and spread, and unfortunately, it has a high rate of coming back even after treatment.
That parallel with malignancy is striking, but what are the core biological characteristics of this ectopic tissue once it's, set up shop outside the uterus?
Well, its defining feature is its absolute dependence on hormones. It's almost exclusively a disease of the reproductive years. You very, very rarely see it before menarche, and it typically fades away after menopause.
Yeah.
Unless, of course, the patient is on hormone replacement therapy.
Because the tissue itself responds to hormones.
Precisely. This ectopic tissue thrives because it responds cyclically to ovarian hormones, essentially mimicking what happens inside the uterus each month. You'll always find proliferative endometrium in these implants. But whether you see secretory endometrium, the post-ovulation phase, that depends entirely on whether progesterone receptors are present in that specific ectopic tissue.
Ah, okay, so it's not just passive tissue, it's actively cycling.
Exactly. And this cyclical bleeding, or maybe more accurately, oozing in these trapped locations, is the absolute core of the pathology. This localized bleeding kicks off an intense inflammatory reaction.
Which leads to?
Adhesions. Scarring. Organs getting stuck together, fixed in place. And that's the root cause of the chronic, often debilitating pain complex that patients experience. Though, it's crucial to add, actual malignant transformation is extremely rare, despite how proliferative this tissue is.
That distinction is vital, the inflammation from trapped blood causing the damage. Okay, let's pivot to the why. Why is incidence apparently climbing? We mentioned better diagnostics like laparoscopy, but what about societal or genetic drivers?
Yeah, the rise is partly diagnostic for sure. But changing social patterns play a role too, things like later marriage, smaller families. It means women have more years of uninterrupted menstrual cycles, potentially more opportunity for the disease to establish.
More cycles, more potential spill.
Potentially. Affluence is also statistically linked somehow. And as we said, it's strongly associated with infertility. But the biology is undeniable. There's a familial tendency in about 15% of cases, and genetics account for maybe 10% of the overall risk. And this is a key number. Having a first-degree relative, like a mother or sister, with endometriosis increases a woman's own risk by a staggering 7-fold.
7-fold. Okay, that clearly points to a strong predisposition, not just random chance. So let's tackle the big theories about how this tissue physically gets outside the uterus. The sources say no single theory fits all cases, so we need to understand all three.
We do. The most cited one, sort of the default for pelvic disease, is the implantation theory. This was proposed by Sampson back in 1922. The idea is simple. During menstruation, some endometrial fragments flow backward through the fallopian tubes, that's retrograde menstruation, and these fragments then land on, implant, and grow on the pelvic peritoneum or nearby organs.
Okay, retrograde menstruation. What's the solid evidence backing that up?
There are several lines. First, you often see scar endometriosis pop up after surgeries where endometrial tissue might have been spilled. Think classical C-sections, hysterectomies, myomectomies, even episiotomies.
Makes sense. Direct seeding.
Right. Second, its occurrence in young girls with cryptomenorrhea. That's where there's a blockage preventing outward flow, forcing everything backward is pretty compelling evidence too.
So if the tissue gets backed up, it can implant. What else?
Well, there's also a suggestion about the mechanics. Maybe reduced tone or hypotonia at the uterotubal junction could allow more retrograde spill during menstruation. So it might be a mix of how much spills back and how viable that spilled tissue actually is.
All right, that covers tissue traveling backward via the tubes. But what about the idea that tissue might just arise where it's found without needing to travel?
That takes us to the coelomic metaplasia theory from Meyer and Ivanov around 1919. This theory suggests endometriosis doesn't travel, but arises from metaplasia, a transformation process in embryonic cell rests left over in the lining of the pelvis, the embryonic mesothelium.
And the link is that the reproductive organs also come from this tissue.
Exactly. The Mullerian ducts, which form the uterus and tubes, arise from these same cells. So the theory proposes that hormonal stimulation later in life triggers these dormant cell rests that change into endometrial-like tissue right there where they sit.
Okay, this helps explain some of those unusual pelvic sites that seem hard to reach just by retrograde flow.
Precisely. And then there's the third one, the metastatic theory. Helbin and others proposed this around 1924, and it's really needed to explain the truly remote sites. This theory argues that endometrial fragments actually embolize. They travel through the bloodstream or lymphatic channels like tiny little cellular clots.
And this explains finding endometriosis in, say, the lungs.
Yes, or the umbilicus, the ureter wall, the bowel wall. And critically, endometrial tissue has actually been found inside pelvic lymph nodes in up to 20% of women with endometriosis, which is direct evidence of lymphatic spread. This is the mechanism you need to invoke for implants found far away lung, pleura, even the heart lining or extremities.
So the big takeaway here for understanding and treatment is that you probably have multiple mechanisms at play. Maybe spill explains disease in the pouch of Douglas, metaplasia explains rectovaginal disease, and metastasis explains a lung nodule. No single theory is the whole story.
That's the crucial point. It's likely multifactorial depending on the specific site of the disease.
Okay, so the tissue gets there through various routes, but what makes it actually stick and grow once it lands? This brings us right back to the hormonal environment and, really importantly, the immune system's role.
Right. The development and, crucially, the maintenance of endometriosis are fundamentally driven by estrogen. It's the fuel. We see the disease regress or get suppressed whenever we create a low estrogen state.
Such as?
During pregnancy, because progesterone levels are so high. After surgical removal of the ovaries, oophorectomy. Through radiation therapy that destroys ovarian function. Or, pharmacologically, by using anti-estrogenic drugs. Estrogen really is the lifeblood for these lesions.
And this circles back to that slightly surprising piece of data about lifestyle factors. If estrogen fuels growth, then anything reducing estrogen could theoretically be protective, even if it's harmful in other ways.
That's exactly right. The sources confirm that smoking, on average, reduces systemic estrogen levels. So purely in the context of this specific disease, that lower circulating estrogen actually provides a degree of protection, reducing the incidence of proliferation.
It's a biological quirk, isn't it? A harmful behavior having a specific protective effect here.
It is. It's a profound point for anyone studying this. Now, if Sampson's theory is right, and most women have some retrograde menstruation, some spill, why doesn't every woman develop endometriosis? There must be something else going on, a biological filter that fails in some people.
That's the million-dollar question, isn't it? And it leads straight to the immune system.
It really does. This introduces the role of immunological surveillance. Normally, when menstrual blood spills into the peritoneum, the fluid there contains a potent cleanup crew. Macrophages, various cytokines, natural killer cells, or NK cells. Their main job is to clear out that spilled blood and destroy those foreign endometrial fragments before they get a chance to implant.
So in women who do develop endometriosis, this cleanup crew fails.
Precisely. The source material points towards impaired function of T cells and NK cells, along with a generally altered local immune environment in the pelvis. This failure of local immunological surveillance means those spilled endometrial fragments just aren't cleared efficiently. They survive, they implant, they establish a blood supply, and they start to grow.
So it's a clear failure of the body's defense mechanism in those susceptible individuals. Okay, let's just quickly consolidate the other key risk factors we touched upon.
Sure, we mentioned genetics at 10% basis, 15% familial tendency.
Okay.
Then there are the mechanical factors. These increase the spill risk. Things like polymenorrhagia, having more frequent periods or heavier bleeding, having a retroverted uterus, which might ankle spill differently, and any kind of outflow obstruction like vaginal or cervical atresia. Basically, anything increasing the volume or frequency of retrograde flow ups the risk.
And conversely, what factors seem to protect against it?
The protective factors mainly work by reducing menstrual exposure. Having had children, multiparity is associated with lower incidences, and using combined oral contraceptives, which suppress endometrial growth and significantly reduce menstrual flow.
Right. And one last factor we need to highlight is prostaglandins.
Yes, absolutely critical for understanding the pain. These inflammatory mediators are actually secreted by the endometriotic tissue itself. They build up in the peritoneal fluid and are major drivers of the chronic pelvic pain and the severe dysmenorrhea the patients experience. They directly contribute to the inflammatory soup in the pelvis.
Right. We've covered the why and the contributing factors. Now let's get visual. When we actually look inside, surgically, where does this tissue typically land, and how do we classify how bad it is?
Okay, location-wise, it heavily favors the lower pelvis. In decreasing order of how often we see it, the number one site is the ovaries. Then, very commonly, the pouch of Douglas, that space behind the uterus, the cul-de-sac. Also, the uterosacral ligaments, which support the uterus, the broad ligaments, and the peritoneum covering the bladder.
And what about those really distant metastatic sites we discussed?
Those are much rarer, but they prove the metastatic potential. We're talking the appendix, the inguinal canals, the ureter, bladder wall, and even lungs or pleura. And we must remember scar endometriosis too, although it's less common now with modern C-section techniques.
Got it. Let's break down the visual appearance, the pathology, into the three main types. Starting with the scattered pelvic disease, what do those implants look like over time?
Right, pelvic endometriosis lesions really evolve. They start out as active, early lesions, maybe small, red, pimple-like vesicles, sometimes filled with blood, indicating active oozing. Over time, they mature into the more classic appearance, dark red, bluish, or even black cystic areas. Those characteristic puckered spots we look for.
And that leads to the classic term you hear all the time, powder burnt.
Exactly. The powder burnt lesions are the old, inactive, scarred down ones. They're often surrounded by quite dense fibrosis. But you also see atypical or healed lesions, which can be tricky. They might just look like non-pigmented or yellowish-white thickened plaques, or even just small defects or windows in the peritoneum.
It's not always the classic black spots.
Not at all. And a key technical point here relates back to that inflammation. The levels of things like tumor necrosis factor, TNF, and matrix metalloproteinase inhibitors, MMPs, enzymes involved in tissue breakdown and invasion, are significantly elevated in the pelvic fluid. This ties back to that cancer-like invasive behavior we mentioned earlier.
Okay, type 2, the ovarian form, the chocolate cyst.
Ovarian endometriosis, or endometriomas, commonly called chocolate cysts. These are critically important because they're the most common single manifestation. They typically form when the ovarian surface invaginates, creating a cyst that then fills with this characteristic thick, dark brown fluid. It's essentially old, altered blood pigments, primarily hemosiderin.
And this is where the histology gets interesting, maybe even counterintuitive for diagnosis.
Yes, it's a crucial detail for anyone looking at pathology reports. Getting definitive histological confirmation can be challenging because the actual cyst lining often lacks the typical endometrial glands and stroma you'd expect to see.
So what do you see?
Instead, pathologists look for a layer of large cells packed with brown pigment found just beneath the cyst's epithelial lining. These are called pseudoxanthoma cells. They're basically large scavenger cells, macrophages, that have gobbled up all the chronic blood pigments. Biopsy here is absolutely essential to differentiate it from other things that can look similar, like a hemorrhagic corpus luteum cyst.
Right, and finally the third type, rectovaginal endometriosis, which you flagged as potentially having a different origin.
Rectovaginal endometriosis is often considered a separate entity. Its origin is thought to be different, likely derived from embryonic Müllerian tissue remnants supporting that metaplasia theory we discussed. Pathologically, it's defined by an incredibly aggressive fibrotic reaction.
More scar tissue than active glands.
Much more. It contains significantly more fibrous tissue relative to glandular tissue. This leads to these dense, hard, often yellowish-white nodules and adhesions. It makes it extremely painful and notoriously resistant to hormonal treatments.
Okay, pathology covered. Now, staging. This is fundamental for comparing treatment outcomes, but you mentioned it needs careful interpretation.
Absolutely. The standard is the American Society for Reproductive Medicine, or ASRM, revised classification from 1996. It's a point-based system based on what's seen at laparoscopy, the appearance, the site, the depth of implants, how extensive the adhesions are, and whether the cul-de-sac is obliterated.
And here's the crucial nuance everyone needs to remember.
Right. The ASRM staging score correlates primarily with fertility outcome. It does not necessarily correlate well with the severity of the patient's pain symptoms.
So a high stage doesn't automatically mean high pain.
Correct. A patient's pain level is much more closely related to the depth and location of the lesions, particularly deep infiltrating lesions, rather than the total point score or overall volume of superficial disease.
That's a vital distinction. Let's quickly walk through the stages and point thresholds just to anchor them.
Okay. Stage I, minimal. That's just 1 to 5 points. Think small, isolated spots, often found incidentally in someone without symptoms. Stage 2, mild. Needs 6-15 points. Here you see more scattered, fresh, superficial lesions, but importantly, no significant scarring or adhesions yet. Stage 3, moderate. Score is 16-40 points. Now, the ovaries are typically involved, maybe with endometriomas up to 2 centimeters. You start seeing some minimal adhesions around the tubes or ovaries, indicating early scarring and retraction. Stage 4, severe. Anything over 40 points. This is the most extensive disease. Large endometriomas over 2 centimeters, dense adhesions that severely restrict organ mobility, often thicken uterosacral ligaments, and potential involvement of the bowel or urinary tract.
Looking at the scoring sheet itself, some findings carry huge weight. What are the big point drivers?
The complete obliteration of the cul-de-sac, that space behind the uterus being totally fused shut by adhesions, that alone scores a massive 40 points. Instantly stage 4. Yeah. And the condition of the fallopian tubes is heavily weighted too. If the fimbriated end of the tube is completely closed off by adhesions, that single finding scores 16 points. Also, deep lesions, regardless of their surface area, score more points than superficial ones.
Yeah.
Depth matters significantly in the scoring.
Okay, this next part connects all that pathology to the patient's actual experience. For the listener, this is about recognizing the signs. What are the classic symptoms, and who typically presents with them?
Demographically, it most often affects women around the age of 30, but we absolutely have to remember it can occur in adolescence, especially if there's some kind of outflow obstruction causing that retrograde flow. And rarely, yes, in postmenopausal women on HRT. But, and this is crucial for any clinician, a full 30% of patients diagnosed laparoscopically are completely asymptomatic. The disease is found incidentally.
30%, so nearly a third feel nothing.
Correct. But for the 70% who do have symptoms, dysmenorrhea, painful periods is the absolute hallmark. Around 70% experience this, and the timing is often quite specific, almost pathognomonic. The pain typically starts before the period begins, often building in intensity for a day or two, peaks around the start of flow, and then gradually subsides as the period progresses. The quality varies: hugely dull ache, grinding, colicky, bearing down pain. Backache is also very common alongside it.
And since we established staging doesn't correlate well with pain, what does dictate how much pain someone feels?
It really comes down to location and depth of the implants. Deeper lesions, the ones infiltrating into the tissue under the peritoneum or near nerves, cause significantly more pain than superficial spots, even if the overall volume of disease, the stage score, is lower.
It's about where it is and how deep it goes.
Exactly. And that chronic pain is intensely linked to those prostaglandins and other inflammatory mediators accumulating in the pelvic fluid. They directly irritate nerve endings, and the fibrosis can even entrap nerves.
What other major symptoms usually bring patients in?
Dyspareunia pain during deep penetration with intercourse is extremely common. This is usually due to the disease-causing fixation and thickening in the cul-de-sac and the uterosacral ligaments.
Yeah.
Any movement or pressure there becomes painful.
And the big one, infertility.
Yes, Infertility affects a significant proportion, somewhere between 30 and 40% of women with endometriosis. And the reasons why it causes infertility are actually quite complex. It's not just one thing.
Let's unpack those infertility mechanisms. It's more than just blocked tubes.
Oh, much more. Structurally, yes, adhesions can distort the tubes, block them, or interfere with the delicate fimbria trying to pick up the egg from the ovary. That's the mechanical side.
Okay, what else?
Biochemically, remember those activated macrophages in the peritoneal fluid, the ones that fail to clear the initial spill? There's evidence they might actually attack or immobilize sperm, preventing fertilization. The whole inflammatory environment in the pelvis is likely hostile to conception.
Wow. And you mentioned hormonal disruption, too.
Yes, particularly LUF syndrome, that's luteinized unruptured follicle syndrome. What happens here is the follicle develops normally, it gets hormonally luteinized as if it's ovulated, but it actually fails to rupture and release the egg. So you get the hormonal signals of ovulation, but no egg is actually available for fertilization.
So multiple potential hits to fertility. Now, we talked about remote sites. How do those manifest symptomatically?
It can be quite dramatic, really underscores how systemic this can be. If it involves the bladder wall, patients might get cyclical hematuria blood in the urine, specifically around their period. If deep adhesions constrict or kink the ureter, it can lead to kidney swelling, hydronephrosis, and potentially long-term kidney damage.
And bowel involvement.
That causes cyclical GI symptoms. Painful bowel movements, dyschezia, constipation, diarrhea, bloating, sometimes even cyclical rectal bleeding or melena, timed with their periods. And in those very rare lung cases, patients can present with cyclical hemoptysis, coughing up blood during menstruation.
Jarring symptoms. Now, when we do the physical exam, what specific findings strongly suggest endometriosis?
The absolute pathognomonic sign, though not always present, is actually visualizing bluish, blackish, or reddish puckered spots or nodules in the posterior vaginal fornix during a speculum exam. These lesions are usually exquisitely tender if you touch them with a cotton swab.
And on bimanual exam?
The uterus itself often feels tender. It might be fixed in place rather than mobile, and it's commonly retroverted, tilted backward due to adhesions pulling it back. Feeling the uterosacral ligaments and the pouch of Douglas area is key. They often feel thickened, nodular. The classic description is a shoddy or cobblestone feel. Even significant tenderness in the lateral fornices without a distinct mass can suggest deep infiltrating disease.
Okay, clinical picture is clear. How do we get the definitive diagnosis?
Laparoscopy remains the undisputed gold standard. It's the ultimate tool because it's both diagnostic and potentially therapeutic. It allows direct visualization of the pelvis. You can see the characteristic lesions, the powder-burn spots, the cysts, the adhesions. You can take biopsies for histological confirmation, and you can perform accurate ASRM staging right then and there.
What about the blood test, CA-125? It gets ordered a lot. What's its actual role?
Right, CA-125. It's a glycoprotein, and it is elevated, usually above 35 units per milliliter in about 80% of women with endometriosis. And the level often does correlate somewhat with the extent or stage of the disease, but crucially, it is not specific at all. It's also rising in many other conditions: pelvic inflammatory disease, tuberculosis, ovarian cancer, even fibroids, or just menstruation itself sometimes. So it's pretty useless for initial diagnosis. Its main value is in follow-up after treatment. If the level was high before surgery and drops afterwards, a subsequent rise might indicate recurrence or persistence of the disease.
So monitoring, not diagnosis. What about imaging like ultrasound or MRI?
Transvaginal ultrasound is actually very good, especially for identifying ovarian endometriomas, those chocolate cysts. They have a typical appearance: thick, often slightly irregular walls, and the fluid inside can be echo-free or have characteristic low-level, diffuse ground glass echoes. MRI can provide excellent detail, particularly for visualizing deep infiltrating nodules, like in the rectovaginal septum or thickened ligaments. It can be very helpful in complex cases or for surgical planning, but for routine initial diagnosis of pelvic disease, a good quality ultrasound is often sufficient and more accessible.
Right. We've got the pathology, the symptoms, the diagnosis. Now, the crucial part for the professional: how do we treat it? The goals seem clear. Eradicate the disease if possible, relieve the symptoms, and if the patient desires, help them conceive.
Exactly. And treatment has to be highly individualized. You're balancing the patient's age, the ASRM stage, or severity. What their main complaint is it primarily pain or infertility, their future fertility desires, and how they've responded to any previous treatments.
Any preventative measures?
Some basic prophylaxis is suggested. Low-dose combined OCPs can reduce menstrual flow, potentially reducing retrograde spill. Avoiding procedures like tubal patency tests right before a period,
Yeah.
scheduling pelvic surgeries for just after menstruation finishes, and avoiding outdated surgical techniques like classical C-sections where possible. For very minimal asymptomatic disease found incidentally, sometimes just observation for 6 to 8 months is reasonable.
Okay, let's dive deep into drug treatment. The core idea is inducing that low estrogen state to make the ectopic tissue atrophy, right?
That's the fundamental principle of hormonal management. You're trying to create a hormonal environment that causes decidualization, a pregnancy-like change, and ultimately atrophy of the endometrial implants. Superficial peritoneal lesions tend to respond much better than deep fibrotic nodules or large endometriomas.
But there's a major caveat with hormonal therapy.
An absolutely crucial limit. Hormonal therapy only suppresses the disease while the patient's taking it. It does not eradicate the underlying pathology. This means recurrence rates are unfortunately very high once the medication is stopped. And, critically, for many patients, most of these hormonal treatments also act as contraceptives, so they inherently delay any attempt to achieve pregnancy.
That's a key trade-off. Let's break down the specific drug classes, starting with the common suppressors.
Okay, first line is often combined oral contraceptives, OCPs. Used continuously skipping the placebo week, they suppress ovulation and menstrual bleeding, inducing a decidualization and atrophy, which significantly alleviates symptoms for many.
Continuous use is better than cyclical?
Generally preferred for symptom control, yes. But you have to counsel about the potential long-term risks, like thromboembolism, especially with prolonged use. Formulations like Seasonal, designed for only 4 cycles per year, are a great option to drastically reduce the frequency of menstruation and potential symptoms.
What about progestogen-only options?
Progestogens are another mainstay. Drugs like northisterone, dydrogesterone, or medroxyprogesterone acetate, MPA, often given continuously for maybe a 9-month course, create a state of pseudopregnancy, leading to decidualization and atrophy of the implants.
And this brings us to a unique player you highlighted. Dydrogesterone, especially regarding fertility. Why is it different?
This is a really vital clinical pearl. Dydrogesterone, particularly when used cyclically in the luteal phase or even at low continuous doses, often does not prevent ovulation. This makes it practically unique among the effective hormonal treatments. It can provide some disease suppression and symptom relief while allowing a woman to actively try to conceive. All the others essentially shut down that possibility during treatment.
That's huge for infertile patients. What about localized progestogen delivery?
The Mirena IUCD, levonorgestrel-releasing intrauterine system, is excellent here. It delivers progestogen directly to the uterine lining and pelvic environment for up to 5 years. It's highly effective at reducing both pain and heavy bleeding, menorrhagia, which often coexists, especially with adenomyosis. It achieves this with minimal systemic absorption and side effects, making it ideal for women suffering mainly from pain or bleeding who have completed their families.
Okay, moving up the ladder to the more powerful but perhaps more problematic suppressors, danazol.
Danazol. It's a synthetic derivative of testosterone, and it works by inhibiting gonadotropin release from the pituitary gland. It is highly effective. Studies show resolution of implants in around 80% of cases.
No.
It used to be a cornerstone of treatment. But the side effect profile is significant and often poorly tolerated. We're talking androgenic effects like weight gain, acne, hirsutism. Also, hypoestrogenic effects like hot flashes, vaginal dryness, breast atrophy. More concerning are potential mood changes like depression and rare but serious risks of liver or renal issues, especially at higher doses. Plus, it's strictly teratogenic, absolutely contraindicated if pregnancy is possible. And frankly, there's been growing reluctance to use it due to its side effects and some lingering concerns about potential long-term risks like ovarian cancer, though that link is debated.
So, often avoided now if possible. What about the GnRH analogs? These sound powerful.
They are. GnRH analogs like goserelin Zoladex or Lupron, work in a fascinating way. Continuous administration actually downregulates the pituitary gland's receptors, paradoxically shutting down gonadotropin release and leading to a profound state of hypoestrogenism, essentially a temporary reversible medical menopause. This causes significant atrophy of implants in up to 90% of cases.
Better tolerated than danazol generally.
Systemically, yes, fewer androgenic side effects. But the major limitation is the consequence of that profound estrogen deficiency. Using them for longer than 6 months typically leads to significant menopausal side effects, severe hot flushes, vaginal dryness, mood swings, and most critically, progressive osteoporosis and loss of bone mineral density.
6 months isn't very long for a chronic disease. How do we get around that bone density issue to allow longer treatment? This seems key for advanced management.
This is where add-back therapy comes in. It's a crucial strategy. By giving back very small, carefully calculated doses of estrogen, usually combined with a progestogen, or just a progestogen alone, or sometimes drugs like tibolone, or even bisphosphonates like etidronate, alongside the GnRH analog.
You counteract the side effects.
Exactly. You manage the worst of the hypoestrogenic side effects, particularly the bone loss, without providing enough estrogen to significantly reactivate the endometriosis lesions. It's a balancing act. But successful add-back therapy allows GnRH analog treatment to be safely extended for up to maybe even 2 years in some protocols, providing much longer-term suppression.
That's a sophisticated approach. Any other drug classes worth mentioning?
Briefly, aromatase inhibitors like letrozole or anastrozole. These block the enzyme that converts androgens into estrogens, working both systemically and potentially reducing local estrogen production within the implants themselves. They can be very effective, especially in refractory cases, but because they also lower estrogen significantly, they carry that same risk of bone loss and must be co-prescribed with calcium and vitamin D, often with bone density monitoring. And of course, NSAIDs, like mefenamic acid, are widely used just for symptomatic pain relief, targeting the prostaglandin pathway, but they don't treat the underlying disease.
Okay, that covers the medical arsenal, but you said surgery is often preferred first line, especially for infertility.
Yes, particularly for infertility, because all those medical therapies inherently delay conception. For younger women wanting to preserve fertility, the goal is always conservative surgery, aiming to remove the disease while preserving the tubes and ovaries. And laparoscopy is overwhelmingly the preferred approach. Minimal invasion, quicker recovery.
Let's detail the key laparoscopic techniques. What are we doing in there?
Several things: destruction or ablation. For smaller implants, usually less than 3 centimeters, we destroy them using energy sources. This can be electrocautery, or increasingly preferred, laser ablation, like NDYAG or CO2 lasers.
Why laser?
Laser offers much more precise control over the depth of tissue destruction. You can vaporize the lesion without causing excessive thermal damage to underlying structures like the bowel or ureter. This precision generally leads to fewer post-operative adhesions compared to less controlled cauterization. Managing chocolate cysts, endometriomas, is a bit controversial. Excising the entire cyst wall cystectomy provides the best results in terms of reducing long-term pain and lowering the chance of the cyst recurring.
But there's a downside.
Yes. The risk is that when you strip out the cyst wall, you might inadvertently remove some healthy ovarian tissue attached to it, potentially reducing the woman's ovarian reserve for future fertility potential. So especially in younger women where fertility is paramount, some surgeons prefer just draining the cyst and then cauterizing or ablating the inner lining of the cyst wall rather than full excision. It's a trade-off between recurrence risk and preserving ovarian function. Adhesiolysis. This is meticulous surgical dissection to cut and remove adhesions that are binding organs together. This can restore normal anatomy, improve tubal function, and relieve pain caused by organ fixation. Nerve ablation. For patients with severe, debilitating midline pelvic pain that hasn't responded to other treatments, specific nerve interruption procedures can be done laparoscopically. These include presacral neurectomy, PSN, or LUNA, laparoscopic uterine nerve ablation. They aim to cut the sensory nerve pathways from the uterus.
And after all that careful conservative surgery, what are the realistic chances of pregnancy?
The outcomes are definitely tied to the initial severity, the ASRM stage. Generally, you see pregnancy rates around 70% following surgery for mild stage 3 disease, maybe dropping to 50% for moderate stage 3, and perhaps 40% or slightly less for severe stage 4 endometriosis.
When does the conversation shift towards more radical surgery, like open laparotomy or even hysterectomy?
Laparotomy open surgery is usually reserved now for very advanced stage 4 disease with extensive adhesions or large, complex masses where laparoscopy might be too difficult or unsafe. Or perhaps if medical therapy has completely failed and the patient is deaf and damaged, they don't want future fertility. It's also sometimes necessary for recurrent disease after previous surgeries, as repeat laparoscopy can be technically very challenging due to scar tissue. The procedures might then include hysterectomy, possibly with removal of both tubes and ovaries, BSO, especially if the woman has completed her family and wants definitive treatment.
And specifically for infertility management.
For mild endometriosis, the approach is often surgery first, followed by trying naturally or moving to ovulation induction with IUI, or potentially IVF if needed. For more advanced disease, the options are often complex reconstructive surgery, tuboplasty, versus going straight to IVF. Sometimes a course of medical suppression, like 3 months of GnRH analog, is used before IVF to try and quiet down the inflammation and potentially improve implantation rates.
Okay, we need to tackle two specialized forms that often present unique challenges. Adenomyosis, endometriosis within the uterine wall, and that deeply invasive rectovaginal disease. First, adenomyosis. What's the core pathological difference here?
Adenomyosis is distinct because the ectopic endometrial tissue glands and stroma isn't just outside the uterus, it's found deep within the muscular wall of the uterus, the myometrium. The definition usually requires it to be at least 2.5 millimeters below the basal layer of the endometrium, embedded right in the muscle.
Who tends to get this and how common is it?
It's actually very common, particularly in older women who have had children, Paris women. It's found in over a third of hysterectomy specimens from women over 40. It also frequently coexists with other things like uterine fibroids or with pelvic endometriosis itself at about 50% of cases.
What does the uterus look like and what are the classic symptoms?
Grossly, the uterus is typically symmetrically enlarged, maybe feeling bulky or boggy, but usually not bigger than a 12-week pregnancy size. It's often described as having a diffuse striated appearance on cut section, maybe with tiny dark hemorrhagic spots within the muscle, often more prominent in the posterior wall. Clinically, there are two cardinal symptoms: menorrhagia, heavy or prolonged periods, and, the real key differentiator, aggressively increasing dysmenorrhea. The period pain gets worse over time. That worsening pattern is often what distinguishes it from fibroids, which, even if large, are less likely to cause such severe escalating pain. On examination, the uterus feels symmetrically enlarged and is often quite tender to palpation.
Now, given that the tissue is trapped deep inside the muscle, why is diagnosis tricky and why is medical treatment often disappointing?
Diagnosis can be challenging. MRI is generally considered superior to ultrasound for visualizing it. Ultrasound might just show ill-defined, hypoechoic, darker areas or striations within the myometrium. MRI can better delineate the junctional zone thickening characteristic of adenomyosis, and the management is difficult precisely because of that location. The endometrial tissue is deep within the thick uterine muscle. This means hormonal therapies, OCPs, progestogens, even GnRH analogs do not penetrate well enough into the muscle to effectively reach and suppress all the ectopic tissue. So unlike pelvic endometriosis, adenomyosis generally responds poorly to hormone therapy.
So if hormones don't work well, what are the options? Hysterectomy is common if fertility isn't desired.
Yes. For women who have completed their families and are significantly symptomatic, total hysterectomy is often the most definitive and common treatment, providing complete symptom resolution.
What about younger women who still want children?
That's much tougher. Sometimes, if the adenomyosis is localized into a distinct nodule, an adenomyoma, conservative surgical resection, basically cutting out that affected chunk of muscle, can be attempted. But the results are variable, recurrence is possible, and there are risks associated with operating on the uterine muscle, including potential uterine rupture in a future pregnancy. For symptom relief without definitive surgery, the Mirena IUCD can be quite helpful for the heavy bleeding and somewhat for the pain. NSAIDs are used for pain too. But overall, medical management results are often unsatisfactory long-term.
Okay, lastly, let's revisit that rectovaginal septum endometriosis, the really aggressive fibrotic form.
Yes, this is a particularly challenging subtype. As we mentioned, its distinct behavior and poor hormonal response strongly suggest it might arise from embryologically derived Müllerian tissue fitting that metaplasia theory. Pathologically, it's all about the fibrosis. It aggressively infiltrates the area between the rectum and vagina, involving the uterosacral ligaments, the posterior vaginal fornix, and often invading directly into the anterior wall of the rectum or sigmoid colon. It typically looks like dense, yellowish-white scarred tissue rather than the typical bluish cysts.
And the symptoms reflect that deep invasion, especially towards the bowel.
Absolutely. Beyond the severe dysmenorrhea and deep dyspareunia, the bowel involvement causes very specific and often debilitating rectal symptoms: painful defecation, dyspepsia, chronic constipation, sometimes alternating with diarrhea, and even cyclical rectal bleeding during periods. And the fibrosis can be so dense it actually compresses the ureters as they pass nearby, potentially causing silent kidney damage if not recognized.
Given the poor response to hormones, what's the primary treatment approach?
Because hormones work poorly here, laparoscopic surgery aiming for complete excision of the fibrotic nodules is really the treatment of choice. This is often complex surgery.
Requiring bowel expertise sometimes.
Frequently. Because the bowel wall is often directly invaded, meticulous dissection is needed, and sometimes a segment of the bowel needs to be resected if there's significant narrowing or stricture formation. This means preoperative bowel preparation is essential, and collaborating with a colorectal surgeon is often necessary for these cases. Interestingly, though, similar to adenomyosis, the Mirena IUCD has been shown to be surprisingly effective for managing the symptoms, pain and bleeding, associated with rectovaginal endometriosis, even though it doesn't remove the deep fibrotic tissue itself. #UTRO.
Wow. Okay, this deep dive has really pushed us, I think, towards that mastery level. It's clear that endometriosis and adenomyosis, while related, have overlapping but definitely distinct origins, pathologies, responses to treatment, and importantly, different ways of measuring severity. The spectrum is huge, isn't it? From tiny, silent implants to conditions that profoundly impact fertility and quality of life.
Absolutely. And for the professional listening, let's crystallize those critical takeaways. Laparoscopy remains the absolute gold standard for diagnosis and staging. Medical treatment hormones, GnRH analogs, they suppress symptoms, they suppress disease activity, but they inherently delay fertility and don't offer a cure.
But remember that key exception.
Always remember dydrogesterone. It's unique in often not preventing ovulation, making it a viable option for women actively trying to conceive while needing some suppression.
And critically, when interpreting severity, never conflate the two metrics. The ASRM staging score correlates with fertility outcomes, not necessarily with pain levels.
Right. Pain severity is fundamentally driven by the depth, and the specific location of the lesion's deep, infiltrating disease hurts more, regardless of the total stage score. Surgery, especially conservative laparoscopy, is often preferred for infertility, generally yielding better outcomes with less morbidity than open surgery, particularly in younger women.
The journey to understand these conditions has taken us from, fairly simple mechanical theories of spill right through to complex hormonal interactions, immunological failures involving NK cells and macrophages, and the role of inflammatory mediators like TNF and MMPs. It really emphasizes the need for highly individualized, site-specific treatment plans.
It truly does. The complexity is immense.
So let's end with that provocative thought for you, the listener. We've established that hormonal treatments, while effective symptomatically, are essentially temporary fixes with high recurrence rates once stopped. If we now understand that genetic predispositions and immunological factors are major drivers, what might the future hold? What novel, non-hormonal, potentially permanent treatment pathways could emerge in the next decade? Could we move beyond just suppressing hormones and instead target the faulty immune response directly? Or perhaps block those specific growth factors like TNF or MMP inhibitors that drive the tissue invasion and proliferation? Could that offer a way to truly disrupt the disease process itself, potentially eliminating the need for repeated surgeries or radical interventions down the line? Something to think about.